Hello, my name is Panzica, and I am doing a presentation on my proposition to have a change in practice based on my research findings. As we know, as nurses, evidence-based research is the foundation of our practice, and during this trying time of coming over this pandemic and being worked to the bone, we need to have research that definitely advocates for the nursing profession in general. So my clinical question was very broad at the beginning because I wanted to see what kind of research was out there, what people were concerned of the nursing profession, the nursing working environment for like an acute care medical surgical unit nurses, just based on patient outcomes and satisfaction. So my question was, how does the work environment of the nursing profession on an acute medical surgical unit influence patient outcomes and satisfaction? So I know the environment that the nurses work in, whether it be super specific or not. I wanted to see what was out there, and there is an immense amount of reviews, or article reviews, about nursing and patient outcomes and patient satisfaction. But the one that I really noticed was safe staffing ratios. That was the biggest thing that they correlated to patient outcomes and satisfaction. With that, this information has been out there globally. They use mixed methods research, and evidence is based on meta-analysis. Changes have yet to be made across the country, though. This is probably due to the nursing shortage, but in California, they have implemented the Safe Patient Limits Act, where they are only required, they put a policy set into place in their hospital that nurses can only have a certain amount of patients. I think it's a 4-to-1 ratio. And that has shown great promise. The nursing staff reports less burnout, patient satisfaction has increased, mortality has decreased, and any critical events have definitely decreased at that hospital, where we have seen nurses report they have 6 patients, they feel that their care is not adequate. Patients report that the care is not adequate, especially nurses working 3 or 4 days in a row. I've seen that a few articles were pilot studies, and there was one researcher. She's a educator, and she has done multitudes of studies, whether it be a literature review or kind of like a systemic review of her own research. But she is making it a point that safe staffing ratios will not only increase patient satisfaction, it will decrease burnout and stress in nurses. It will save the hospital costs from decreased length of admissions, decrease hospital-acquired infections, and decrease readmission rates. So why it's not only helping the nursing profession, it's helping the business aspect of the facility. But this research out there has its limitations, just basically due off the qualitative research that it's done. But there needs to be quite a bit more, which why I'm trying to implement this, because I think this is definitely a research and a policy change that needs to be implemented into nursing profession as soon as possible. So I intend to operationalize the practice change in my environment here on a medical surgical unit is at first find out exactly what our nurses need. Is it exactly patient staffing ratios? Is it the environment that is created? Is it management? Just trying to get information on exactly what would help have better patient outcomes and satisfaction. But with my research and my clinical question, I will intend to staff accordingly. Yes, this means higher costs for hiring and training and staffing the floor, but the plan is to go a 4-to-1 ratio maximum, And at the end, this is what the California study showed, that their cost of healthcare actually decreased because patients were not staying in the hospital as long. There weren't hospital-acquired infections, and that there was a low rate of readmission. So where cost can be a big factor here, we know that this is shown to show positive outcomes. So with the nursing research, we use theoretical models, and these will help me overcome some barriers to implement my change to practice. The theoretical model that I will use is the middle range nursing theories. It's also known as the intervention theories. And this refers to that daily practice that's involving the nurses every single day. Their work environment is what I want to research, just to better understand the behaviors and able to permit an effective intervention to change in practice. One of the barriers, like I said before, will be money. That will have to be discussed with hospital administration, just by hiring more staff, paying the staff that is on the unit to work, and also time to do the literature review, the critical appraisal. Time and money are a big barrier. Another big barrier is a resistance to change. Why some people are really good at adapting to change, there's some that aren't, and they will not like the increase in staff, and it could lead to a barrier into my research. So the sources of internal evidence that will be used to provide and to demonstrate improvement in outcomes. Data will come from participants, nursing participants, that will be surveyed in what they think is a normal ratio for patient to staff here, especially on this medical surgical unit. I'll be using the critical case sampling methods and also meta-analysis research and the healthcare databases. I decided to use those in the beginning, even though it may cause bias for my interpretation of the data, because I would like to know what data methods they'd use. I use secondary data analysis, and this is a way to protect the patient's information so that they're protected by HIPAA, and only as much PHI is needed so that their information is not out being researched constantly. So with that, there's no ethical considerations. They are protected by HIPAA, and we're making sure to protect the PHI by only using what we need to. I can effectively evaluate outcomes for my change in the project. One, since outcomes research is providing direct results of the care that was received in this healthcare setting, the surveys, surveying the participant and nursing staff, they can be surveyed after, saying if this is the change in staffing ratios is helping the environment, helping burnout. Also using the quantitative outcomes that we have utilized in our data, with the number of mortality rates decreasing, readmissions decreasing, cost of healthcare would be decreasing, and the length of time in the hospital is decreasing. So all of these qualitative and quantitative data points are able to take behaviors and put them into variables and show that the less patient ratio to nurse that is there, the better the patient outcomes and patient satisfactions are. I will disseminate the findings from my change of project by publishing this research and putting it into healthcare databases, article reviews that other people can use in their research. There isn't a ton of this research. That's why we have to seek out globally to make sure to get enough, a big enough sample size. But the point would be to get legislation to pass the act of the Safe Patient Limit Act, where there'll be policy put into place in the facility that nurses will not be allowed to take larger assignment than a 4-to-1 ratio. And that way it will help with mortality rates, patient outcomes, satisfaction, and costs from the hospital. This research is definitely pertinent at this time where there was a pandemic and nurses were having to take care of as many patients as possible. But now this has not stopped and it has not decreased, and nurses are still required to take care of the same patient load, but more burnt out. But these are the findings of my research and my clinical problem, and I hope it will be able to be implemented globally for all nursing.